the Journal of Child Psychology and Psychiatry, celebrating 60 years of empirical research, clinical studies, and systematic reviews. For details of our 60th anniversary celebrations, visit www.acamh.org/JCPP60. Follow us on Twitter with the handle @thejcpp and use the hashtag JCPP60.
Thank you very much. Madam President, Chair, dear colleagues and editors, I've been trying to find out what the technical term is for a collective noun for editors. On the internet, unfortunately, it's always written by the authors, who have a bad relationship with editors. So the commonest one is a twaddle of editors. I prefer myself an opinion of editors. I think the technical term is a redaction of editors. A bit of a mouthful. I think in this case, we can quite reasonably talk about a family of editors. Because the... Can we have the next set of slides? Yes, thank you. The PowerPoint pause is a hallowed tradition of the academic presentation. Getting over it is another matter. Yes, thank you. And perhaps we can enlarge it.
It's big up there.
Is it?
Yeah.
Oh, that's good. Oh, that's fine.
Sorry.
Fine. Fine. And so to this scribble of editors, or this family, it is striking how many of us in the past have cared deeply for the journal. It's been important in many of our lives. And I'm going to talk a little bit about how the impact ought to work between science and clinical practice. How is it transmitted? How should we measure what we're doing? How should we measure what our impact is? And should we modify our practice? In the history of the journal, and many of the editors in the past have cared for it enough that they wanted to write these various comments, really explaining what the journal's about and what it's trying to do. So let me point out particularly what Mike Berger wrote with the late Lionel Houseoff, which was on the occasion of the 30th anniversary. Dorothy Bishop has done a very scholarly job in editing the cumulative contents of the journal and showing rather graphically what's changed over the years. And in the initial stages of it, it was always very broad. It always had a good aim of bringing the scientist and the practitioner into registration with each other. There was more animal behavior then. There was more sociology then. But the big change over the years, as she's documented, has been in more empirical work. And I think this both reflects how the field has changed, and also it reflects the impact of the journal on changing it. So I do want to argue that probably the biggest kind of impact that a journal like this has on the practitioner is creating a discourse. It's creating an atmosphere in which it's possible to think not only of the narrow evidence base, but also the general principle of the reflectiveness and the rigour and the criticism that clinicians need to bring into practice, and that the journal does stand for and still does. Discourse come in various ways. You have to think in various ways. It's quite a complex issue. What kind of practitioners are we thinking about influencing? there are the opinion formers, and the pharma companies have a well-developed industry of how you modify practice and what the prescribers usually do by targeting the opinion formers. And there's an industry about identifying who the opinion formers are and of cultivating them with research grants, with nice travel, with conferences. On a notch down from the opinion formers, the leaders of the specialty, other specialists, the senior practitioners, the people who are actually running the services. The ACAM members are a very diverse lot, I'm very glad to say. And it's always been an aim of the journal that we're informing the membership. The public health, primary care, policymakers, and therapists all have their own different targets and their own courses of how what you read in the journals influences what people do. I don't think it is usually the romantic view that you have a sudden paper which influences everything and everything changes. It really doesn't work like that. It sounds more complicated. The image that we all have is of T.H. Huxley when he's just read The Origin of Species and he clutches his head. It's how stupid of me not to think of that. And that kind of breakthrough moment is not a common event in science. It's much more an incremental process, of course. It works in different ways. The influences on the practitioners are very different according to where they come from. What kinds of science are we talking about? Well, there's evidence-based medicine, the immediately practical, the result of a trial, the write-up of a trial, or the psychometrics of an assessment process. Quite easy to monitor and describe the process of that happening. And of course, many people here are doing things very like that in developing their impact statements that our masters increasingly demand of us. There's also the whole question of outcomes and risks, which may not have the immediate influence on practice, but mostly speaking personally, it was very important for me in my early career in this country when I was starting to introduce ADHD into the English clinical community and to promote the medical treatments of it, that I could look above the head, so to speak, of my immediate colleagues and my superiors and the leaders of the profession and look to the science. And it was that sense of another court, a different way of doing things, very sustaining, very building of confidence. And so for this practitioner, it was almost the intangibles. No one paper, no one journal, but the general process of care, fidelity, and rigour. Practice, of course, matters in the planning of services, and service use in economics is increasingly a research area in its own right. And it does work differently, I think, about how the science influences the practice in different kinds of service organisation. Where you're publicly funded, as the NHS used to be, whether it's a more competitive mixed system as the NHS is now, or whether it's a privately funded system. Because different rules and incentives apply in the different phases. And the kind of process of implementation is very often a kind of marketing, and you have to think about what the market is doing. Monitoring what the effect can be is a correspondingly complex process. The easy things from citations, from downloads, from the useful altmetric side, from McMaster relevance, which I will mention, and from whether the conclusions of papers are getting into the clinical guidelines, which are what ultimately tends to guide practice. The ACAM members have fed back to us over the years that they want more clinical relevance in what they read in the journal. And that was part of the reason for wanting to start the practitioner reviews in '93. And in Jonathan Green's editorial, which I mentioned before, he became the editor, and he was explaining them to enable practitioners to conceptualize clinical problems, frame clinical observations and assessments, and make treatment plans. So it's quite a general brief. It's not just a contribution to the evidence base. Because we do have a variety of means of trying to achieve it in ACAM. As the chair just mentioned, we not only have the journal, we have child and adolescent mental health, which is widely read by clinicians, the bridge, we have special interest groups, we have newsletters, we used to have occasional papers, podcasts, Mind8, and a lot of other different ways in which we try to inform practitioners about what's new, what's good in practice. And a lot of it is trust, because I think that the brand of ACAM is a trusted source of advice and influence, and it's partly because the journal gives it the credibility of a high-regarded scientific avenue. Trust was going to come and come again, I think, in this discourse. I'm very grateful to Prabha, who's done some very helpful work for me in digging out some of the citation patterns that have been happening. And there's one way of thinking about it. What gets the prize? What is the Gold Cup for most cited paper? That's the Bruce Pennington's review. Not a practitioner review, a paper. It's a good paper. Not widely cited in clinical circles, but it is one that comes up on reading lists. So in the education process, which is where practitioners acquire the understanding of the broad outlines of the topic, I think one can call it an influential paper through that. Gold Cup for longevity of citations goes to number 5 in the total list, which is, has been mentioned already, which is a good example of an evidence-based, directly useful paper. It's describing the psychometrics of an important assessment scheme. And in current practice, its successor, the Strengths and Difficulties Questionnaire, is one of the key things which is used by practitioners to decide which patients they accept and to decide whether they're doing a good job according to what the results are. Limited, I think, for that purpose. You all know the doubts about whether you can really apply a screening system to a clinical diagnosis, and whether a restricted number of symptoms is an adequate way of describing outcome of a complex generic service. But that is very much, nevertheless, the way things are going in this country, especially now, with the government producing a lot of money, well, a bit of money, that is largely devoted to this kind of thing. It's typically papers describing this kind of thing don't only report the sensitivity and specificity, which are very important. But from the point of view of the clinician, it's very more important to report the positive predictive value and the negative predictive value. Because what the clinician really cares about is, does this questionnaire, which says that this person needs referring to my service, does it really mean that? So it's a positive predictive value, which is often very much lower than the sensitivity and specificity would apply. So the direct translation of evidence-based medicine definitely needs to be filtered through the judgment of people who've had the broad education which ACAM is trying to do. You can look at the downloads, and the Gold Cup for most downloads is not actually from the journal, it's from our sister publication of Child and Adolescent Mental Health. It's a review of physical activity programs, the 9,000 downloads. Downloads probably are possibly an improvement in marker, because clinicians do download and learn an awful lot from that. But it's not a great marker. And you have to bear in mind this hugely cited paper from the Lancet itself, which is, of course, the paper in which Andrew Wakefield announced the cause of autism and distorted practice. So a very influential paper on account of autonomy can be a very harmful paper. There are side effects as well of success. Currently cited, the top 5 are mostly meta-analyses. This is in the last couple of years. They're not mostly practitioner reviews, they're annual research reviews. And it is those reviews which are providing an overall account of what's known that get very heavily into the thinking and directly of other scientists and practitioners. And that's where we're most cited, on the whole, in other journals with a similar kind of emphasis. Now, another limitation of citations was rather trenchantly put by Margaret Thatcher when she was being confronted during a Research Excellence Framework report on the reorganisation of medical schools was under discussion, and people were boasting about the size of their impact factors. And she remarked trenchantly that does it matter how much these people talk to each other? Because, of course, it is not clinicians necessarily who are the consuming of this. It's other scientists. The McMaster evidence ratings do try to get a little bit beyond that. It's their system is that for the journals which they scan, including ours, they have an expert panel which rates the extent to which an article is relevant to their clinical practice and the extent to which the clinicians in the rater's discipline are unlikely to know it already. So it's kind of rating of clinical relevance. And they publish regularly the McMaster online rating of evidence, which people may scan. Those who do scan that will be aware that there's not very much child mental health in it. There is some, but the journals from which they select articles on this basis do not include ours. They're all American journals. The Journal of the American Academy is well represented, and in particular, most of the things that they cite are either meta-analyses or guidelines. And I think this does reflect the way that implementation happens. There are lots of ways of describing that. I'm going to stick to the notion of a process model in which information filters through from science into practice. It is an oversimplification, but it does help to focus thoughts. Now, clinicians are often quite anxious, especially if they're starting a new thing. Especially if they're doing something which is not in the conventional wisdom. Maybe it's against the funding outlines of the people who fund them. And the way you get to consensus is quite an official one. I'll give you the example of NICE, which is the British thing, which is laying down guidelines for practice. Not because it's always right, it certainly isn't, but because it's enormously influential. I don't think anyone's been prosecuted for disregarding the guidelines, but several people have had a successful defense in the law courts because their practice could be documented by an appeal to NICE. So when you get towards consensus, you begin with a generalization, the kind of thing you read in a textbook. You go on to a guideline, which is the kind of thing that the senior practitioners will try to follow, which specifies what you have to recommend in a particular instance. You go on to the protocols, which are very largely what the administrators and the managers of services expect and run. For instance, in one case, it would be 100% of referred cases are evaluated by a child psychiatrist. It's their way of knowing whether their wishes and their formulations and their targets are actually being met in the clinic. Now, the inferences on different stages of that process are a bit different. At the general level, it starts with a review, a meta-analysis, all published papers or all papers, all English language papers or all papers, depending on the practice. And it's not conducted by clinicians, it's conducted by experts in systematic review. It's conducted by the people with a special interest in the statistics, including the kind of statistics that I've been talking about the impact which papers have made as a kind of proxy for quality. The result is a draft of recommendations, including the costs, and that is the raw material for a guideline. It's not the end of it, because there's a next stage, which is very much where an expert panel, a panel of clinical experts, and sometimes scientific experts, but mostly clinicians, are refereeing the process. For instance, in the ADHD guidelines, in the original guidelines, we were confronted by the meta-analyses, which said quite clearly that the best thing to do for ADHD was dexamphetamine. They're cheap, effective, powerful. It was turned back by the expert panels from saying not enough knowledge about adverse effects, presence in the abusing community, the price is subject to fluctuations anyway, and from that come the recommendations, which is nearly on the guidelines, but then that is modified to be a guideline by acceptability to users, by economic cost and subgroups. Of course, all those people and all those influences are different. When the filters down to local factors and individual practitioners, a different set of influences apply altogether. And the lower it gets to policy, and when the purchasers decide what to purchase, economic costs, media acceptability, and social critiques are coming very much into the implementation. Sometimes as filters, which determine whether what's in the journals is actually getting through into practice. And at the level where it actually happens, of the individual practitioner, where clinical work happens, then it becomes a matter of marketing. In pharma, that's a very well advanced science. Business. And there are lots of, at the different levels of that process. First of all, there are the influences on experts. And on experts, the financial conflicts that come in can be remarkably strong, all over medicine. And these are examples where guidelines have been heavily questioned because there's so much competing financial interest. The diabetes guidelines, the chairs of the guidelines, of 6 out of the 12 guidelines, were actually members of the advisory boards of companies selling drugs in that area. Similarly with statins, if we come to the Australian guidelines on ADHD, which is a fascinating story in itself, then they've repeatedly been retracted because of not being able to trust the guidelines making them up. First of all, the chair was on the advisory boards of Novartis and Eli Lilly, and then because Joseph Biederman, whose work had been cited 82 times in the guidelines, had the disgrace, not the punishment, but the disgrace of being known to receive undisclosed payments from the manufacturers of risperidone. Maybe it's gone too far the other way. So on this important matter of translating science into practice, NICE has recently disqualified an expert from chairing if they are also people who publish in the field. And so we do need the balance that can and should come from reliable science. So the balance is provided in the well-regarded, the trusted journal, still has its limitations. I'll put them in terms of things that I've heard. A practitioner may well say, I will wait until there's consensus here. But that's what NICE is intended to achieve. And when there is a consensus, if that's wrong, and it often is, that may have a deadening effect on the field. I don't have time to read all these papers. But again, it's partly what we try to do in practitioner reviews, though I don't think they're very much read by individual practitioners. I don't trust a field where there's constant changes of I've got the slides up here, but they're not on the screen, I think. Can we fix that? We're almost at the end. You'll be relieved to hear, Joe. There. I know what it is, trying to...
This is the one.
Thank you very much. Yes, I know it's there, but it's not up there.
I don't know.
Okay, well, okay. It doesn't matter, but if you'll just leave that for me for a minute, because I did want to...
Did you click out?
No, I need to... Just leave it, just leave it. There's a question of whether JCPP should be seeking to increase its clinical impact. And there are various ways that it might be done. It might be that the original papers that we have include a simple version, something short, succinct, not with all the conclusions in all the qualifications to conclusions that are in it, but with the broad outlines of what ought to happen, because that's what will be read by the policymakers. And it's the policymakers who will largely determine what happens. I've suggested the professional process in which implementation happens at a professional level. Increasingly in this country, it's not done at that level. The directions of process are done by governmental fiat and by the managers trying to interpret those. So we could do more in the way of making our practitioner reviews simple, short, and punchy. We could do more translations. Use, for instance, child and adolescent mental health more, use blogs more, use the ability of reaching people outside the print media, which is a tried and tested way of getting the information into in the charities that I work with nowadays.
Okay. This is your set of slides, yeah?
That's my set of slides, yes. We're just trying to get them up on this. In the charities that I work with nowadays, Okay. It was good, but it didn't last. It's like some of the papers that you read in the journals. I'm just giving some examples of the way that nice reviews use JCPP papers. The answer is not much at all. Should we maybe prioritise publication of the kinds of papers that have clear and obvious clinical relevance? Trials, meta-analyses, assessment of instruments, published guidelines. That's certainly what gets you into the McMaster high-impact system. Should we have our own rater panel, as McMaster does, of people, of senior clinicians who are rating for relevance and utility? Or should we employ experts on messaging, as the charities I work with do all the time, in order to get their conclusions, and sometimes they're very feeble research, I have to say, into the minds of ministers and the minds of the senior civil servants? Sleep loss creates depression and ADHD in children. I don't know if you've seen that current example, but that comes from a very inferior survey done by one of the charities for which I'm responsible. I apologise. Because they understand better than the science does about how you get conclusions to influence policy and therefore practice. So they're all things that we could do, but I think there'd be dangers in trying to chase the indices like that. It makes fashion the goal. I think guidelines are increasingly doing that. They're increasingly making medicine a matter of algorithmic following a chart. And when a problem is complicated, you get out of the realm of what the guidelines can tell you. And then it's when you need the person with a broad understanding of the field, which I hope their education will have given them, and which it certainly will have done if it's included the extensive use of the Journal of Child Psychology and Psychiatry. Thank you.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.